Barely existing. American disability benefits versus real cost of living. Today we're breaking down SSI versus SSDI, how much people actually receive in benefits, and comparing that to the real living costs, like housing, Medicare, children, and the impossible math that families live on with disability that they often have to do just to survive. This isn't about individual effort or work ethic. It's about how a system built for older beneficiaries fails the increasing number of people who are becoming disabled earlier on in life, especially families with kids. SSI versus SSDI. The core difference. SSI is supplemental security income. SSI is a needs based, it's not tied to early earning history, and for most people who are disabled or blind or elderly with a very low income and low assets. In 2026, the federal minimum for an individual was $994 per month. For a couple, it was $1,491 a month. But the average SSI payment as of January 2026 is $737 a month for all recipients, including kids and adults, which is well below the maximum. SSI eligibility usually means that you qualify for Medicaid in most states, but benefits are still extremely low, and every dollar of the income counts against eligibility in many cases. SSDI is Social Security Disability Insurance. SSDI is based on your work history and your past earnings, like Social Security retirement benefits, but for disability. Benefits vary widely depending on the earning history, but the average disabled worker benefit in 2026 is about $1,630 per month. The maximum benefit in 2026 for someone who paid into Social Security at high earnings for many years is $4,152, but few people actually hit that. Housing, the gigantic elephant in the room. The average two-bedroom rental across the United States as of early 2026 is roughly $1,800 to $1,900 a month, and rent in many areas is significantly higher. Let's compare the benefits. The average SSI payment is $737 a month. That's about 40% of the average two-bedroom rent. Average SSDI payment is $1,630 a month. That's still less than average for a two-bedroom rent before utilities, food, medical costs, transportation, and any other things that you need. Kids, space, and reality. For families, that housing math gets far worse. A two-bedroom is often the minimum if you have children. Especially as they get older, they need separate rooms for privacy due to their age or gender. Even a third bedroom for older children or any extra support needs can add hundreds of dollars per month, which means that Social Security disability insurance barely covers housing alone, and SSI doesn't even come close. These aren't arbitrary choices. These are human dignity issues with privacy, safety, mental health, development, and none of which has a dollar sign that SSI or SSDI accounts for. Healthcare isn't free, even on disability. One myth is that Medicare comes automatically with disability, so healthcare shouldn't be costly. But here's the reality. Medicare costs in 2026. A Part B premium is $202.90 a month for most people, and it's not free. An annual B deductible is $283 before Medicare pays anything. Most disabled beneficiaries also pay income-related surcharges. We call this IRMAA, on top of their income past work taxes that are high enough, meaning that cost can be $300 to $600 a month depending on income. Medicare covers much, but not everything, and copays, coinsurance, durable medical equipment, prescriptions, specialists, therapy, and out-of-pocket costs can rapidly add up. Also, Medicare is separate from SNAP, TANF, or Medicaid. Just because someone gets Medicare doesn't automatically mean that they get food assistance or income help, and many families earn too much on paper for programs like SNAP or Medicaid, or they don't qualify for waivers, even though they can't afford the living costs. The bigger structural problem. These programs were largely modeled on systems designed for older adults, like retirees in their mid-60s or older, not young disabled adults or families with children. With chronic illness and disabling conditions more common earlier in life, the system is being asked to serve as a demographic that it wasn't originally structured for. SSI limits are countable income and asset thresholds that are very low. $2,000 for an individual, $3,000 for a couple. That means that's all you can have when you make SSI. SSDI recipients can technically have higher incomes, but even average benefits don't come close to meeting the basic living cost, especially once housing, healthcare, food, and transportations are all tallied in. Before food, utilities, childcare costs, education, medical copays, or even transportation, the basics of housing and health insurance costs are more than many disability benefits provide. People think that disability equals comfort. In the reality of it, it's barely surviving, or even worse, it's poverty. This isn't about not wanting to go to work. It's about recognizing that families have responsibilities. Kids need more than just shelter. Healthcare costs aren't optional, and policy hasn't adapted to the rising number of young people with chronic needs. Chronically ill parents raising chronically ill children. The cost nobody budgets for. There's another layer to disability that rarely gets talked about, and it's not just about being disabled. It's about being disabled while raising chronically ill children. And the system was never designed for that. The reality of prioritizing when a parent is chronically ill and their child is also chronically ill, the choice is almost always the same. The child comes first. That means that the child's medications are filled before the parents', the child's specialist's appointments get priority, the child's needs are met even if the parents are delayed. Over time, this has consequence. The parents get sicker, not because they're irresponsible, but because they're managing a system that forces parents to choose between survival and parenting, and parents will always choose their child first. What people don't see is that weekly medical workload becomes a thing. For families with chronically ill children, it often looks like multiple specialist appointments during the week, lab results, imaging, infusions, therapy, follow-ups, coordinating care between providers who don't communicate with each other, managing medications, reactions, insurance approvals, denials, and appeals. This is unpaid labor, full-time labor, on top of being sick yourself. And none of this is accounted for in the disability benefit calculations. Transportation is not free. One of the most dismissive arguments about disabled families is you can just use public transportation. That assumes that public transportation exists. In rural America, it often doesn't. And even where limited transportation programs do exist, they have mileage caps, appointment restrictions, long schedules, long waiting times, limited medical coverage zones, and they still cost money. Gas is not free. Medical transportation is not free. Ride services are not free. And when a car breaks down, there's no emergency transportation fund for disabled families. There's no automatic help. There's no backup plan built into the system. Missed appointments become non-compliant, which can lead to loss of services or loss of benefits. A working vehicle is not a luxury for a chronically ill family. It's a medical infrastructure. When a car breaks down, there's no assistance programs specifically designed for disabled families. There's no repair funds, there's no grace periods, and even if a friend or family tries to help, you may be required to report that income as an income or support. You heard that right. If a family member or friend tries to help, you have to report that as income or support. That is not support. That's surveillance, and it actively discourages community care. The reporting trap. Another truth that people don't understand is that if friends or family step in to help with gas, rides, groceries, or medical costs, that can actually count against eligibility programs for SSI. So families are punished for having a support system, and this forces people into isolation and discourages people for asking for help, and it turns survival into a compliance exercise. That's not humane. The long-term cost is making parents sicker, When a parent consistently delays their own care, disease progression accelerates, complications increase, hospitalizations become more likely, caregiving capacity decreases, and this creates a feedback loop. A sicker parent means a less stable household. A less stable household means higher long-term costs in the system. Preventative care is much cheaper than crisis care, but the system only pays attention once things collapse. Chronic illness and disability are occurring younger and younger. That means more disabled parents raising children, more chronically ill children growing into disabled adults, more families navigating a system that was built for retirees and not young families. We're not planning for their future. We're barely allowing them to survive in the present. What actually needs to change is a system that will actually support disabled families. And that would include things like transportation assistance tied to medical need, not geography. Protection for community and family support without penalty. Recognition of caregiving labor in benefit calculations. Healthcare access that doesn't require parents to sacrifice their own treatment. Policies that are designated for families, not just individuals over 55, because disabled parents do not want to live this way. Chronically ill families do not want to depend on scraps, and our children deserve more than a system that assumes that their parents should quietly disappear. This is not about wanting more. It's about needing enough care, enough stability, enough dignity. A future where chronically ill children don't grow up inheriting a system that failed their parents. We need a call to action. We need benefits to increase, tied to inflation and real living costs, not outdated formulas. We need housing support that actually covers rent, not vouchers that only slightly dent the cost, and wait lists that cause us to wait for years and years. We need modernization of disability policy to account for families, not just individuals over 45, and to end income cliffs that make people too rich for help or too poor to live. This is usually where people ask, so what do? We stop pretending that this is a personal failure, and we stop blaming the disabled parents for a system that was never built for families, never built for rural life, and never built for people becoming disabled in their 20s and 30s. We demand policies that reflect reality. And if you have the power to change the system, understand this. When families are supported early, crisis costs less. When parents stay healthier, children stay safer. And when dignity is built into policy, everyone benefits. It isn't radical, it's responsible, and it's long overdue.